So welcome to this special EBC bifurcation session sponsored by TERUMO. The learning objective of this session is to understand the best treatment option for patients presenting with complex bifurcation lesion, to share a benchtop simulation of bifurcation techniques during the live case, and to learn how to optimize both the strategy and the technique. The case will be performed by José María de la Torre Hernández from Santander. I will describe the case.
To all of you, good morning, Thierry. We have a 65-year-old male patient here. He's ex-smoker. He's the only risk factor, cardiovascular risk factor he has. He's complaining of chest pain at low exercise level, and even Rex in the last 1 to 2 weeks. The episodes are lasting for 5 to 10 minutes. Are short, but he was really concerned, and he attended the ER and was admitted a few days ago. In the EKG was evident the presence of mild ST depression in V5, V6. Mild high-sensitivity troponin I elevation was noted. And in the echocardiography, a normal ejection fraction was evident with no segmental wall motion abnormalities. This is the bifurcation, but I can show you other data because I have the angiography done today again. We did the diagnostic the other last week, and you can see in the slide the bifurcation in the CERT that is really the culprit. But we have here the right coronary artery, which is normal. There is no stenosis in any place in the right. And we have here the angio for the circumflex. It's the same as you can see in the steel frame in the slides. You see a severe lesion in proximal circ, really severe, focal, no calcified. It is involving the proximal part of the bifurcation. Then the side branch is mildly to moderately affected, and the distal main branch is only mildly or not significantly affected. We could say that if we go to the next slide, exactly, this is the Medina 101 classification for this bifurcation. And this is the circumflex, as I say, the lesion, and LAD, no lesions. In the slide, you can appreciate the QCA of the lesion. The main branch proximally is 3.7 millimeters, distally is 3.5, then is small tapering, but it's a large vessel. And the side branch is in diameter, reference diameter 2.6. Then, Thierry, this is the bifurcation we have today. It's 101. And what is your idea about the approach?
I think it's a very nice case. I think, of course, there is many options, but in this particular case, I think provisional side branch treatment is a good one. The lesion is very tight in the circ, so I will start with 2 wires for protection of the side branch. Maybe pre-dilate or not, I don't know what is your current approach.
Yes.
Kind of recent angina, but I think there is many options.
Yes, we agree with Thierry. We are going to approach with a provisional stent, which is the most common approach. And because of very tight lesion, we're going to pre-dilate. We have to use a rear ray balloon, a semi-compliant balloon. Please give me a 3 millimeters, 320 rear ray.
Okay.
We're going to pre-dilate with a 320 to start with. I hope we are going to cross, despite the severity of the lesion. There is no calcium. And we are going to pre-dilate the main branch. We're not going, Thierry, to pre-dilate the side branch because it's very ostial, no calcified, not very severe, normal flow. What do you think?
Yeah, I fully agree. I will not pre-dilate, just protect the branch and decide after stenting the main what we should do in the side. So
yes.
We'll use for stenting Ultimaster Tansai, and you plan to use OFDI at the end of the procedure.
Yes, exactly. That's the idea, to optimize the stenting result by OFDI, balloon wave, and to see we have a good apposition, particularly proximally. We have with expansion and the more critical segment. If we had good coverage, everything. Really, the optimization with the imaging is quite relevant, particularly in bifurcations like this, or leg main, particularly, and other lesions.
So the plan is to use Ultimator Tansai, which is a very nice stent for treating bifurcation lesion because of the open cell design, uniform scaffolding, and also the good expansion capacity when you have discrepancy between the distal reference and the proximal reference. One important question is the strategy for bifurcation, and we have very nice data from the e-Ultimaster registry showing that proximal optimization technique is a crucial step when treating bifurcation lesion. You can see in this very large registry of more than 4,000 patients that if you do proximal optimization technique, you decrease the risk of I, of TLF and stent thrombosis. Unfortunately, in this international registry, only 1/3 of the patients had proximal optimization technique. So it's very important to insist on that. Using POT is a step which is fundamental when treating bifurcation lesion, whatever the technique.
We're pre-dilating. Really, the reed-ray balloon is a very good balloon, a good low profile, good navigation, traceability, and really you have a very smooth transition of these balloons, even through the most tight and severe lesions. We also take advantage of the balloon to make our measurement of the proper stenting, because you can see here, this is the ballooning with the full expansion, the plaque is shoved, and this is the 20 millimeters balloon. Then the stent, as you can see, should be around less than 20 millimeters. Could be 18, for example, or 15 even. We plan to go from healthy to healthy. The distal main branch looks not, geographically not affected, but offshore is going to be in somehow affected. So we have to go across the side branch and to reach, maybe to cover at least 10 millimeters or 8 millimeters off from the distal main branch. Let's see what's the result after pre-dilatation. I'm going to show you, Thierry, this is the result after pre-dilatation, which is good.
Yeah.
And we're moving fast. We are just going to stent the lesion because the behavior of the balloon was very good. There is no calcium. Then we can go from the 3 pre-dilatation to the 3.5 stenting. I don't know what you think, Thierry, but when I don't see calcium, when I see an unstable plaque, I don't pre-dilate with a 1:1. I sometimes go a bit smaller, particularly in unstable lesions, very fatty lesions, in bifurcations, in order to prevent maybe a dissection that is going to make you implant much longer stents. What do you think?
Yeah. Oh, yeah. I fully agree with you. And in many cases, I'm not doing pre-dilatation because when the patient is unstable, usually it's a soft plaque. But if I do pre-dilatation, I use a small balloon.
Exactly.
Smaller than the reference. What is interesting after pre-dilatation is that the proximal part of the vessel looks bigger than 3.7. The QCA showed 3.7 and 3.5 for the distal and the proximal and distal reference, but it looks close to 4, in fact.
Yes, it looks larger. Yeah. When you open the artery, you have more flow and more dilatation of the vessel because of the effect of the flow over the endothelium and all this.
To think about the proximal optimization technique and to have enough space proximal to the carina to be able to do proximal optimization technique according to the balloon that you have in your shelf. So what is the shortest balloon that you have in your cath lab? Is it 8, 10?
We have balloons for 8 millimeters.
Okay.
And we can do, we have 8, we have 10, we have 12. That's good to have, as you say, very short balloons for POT in bifurcations. Absolutely. Because sometimes the proximal part to POT is very short and you don't want to do a geographical maze to dilate with balloons that are longer than the proximal part of the stent.
Absolutely.
We're going to implant a 3.5 millimeters because we just sized the stent with the distal main branch. The distal main branch is for the sizing. And then for the proximal part of the stent, we will do POT with the proper, maybe 4, as you say, millimeters non-compliant balloon. But now the stent is sized by the distal main branch, which is 3.5, as you could see in the QCA analysis. This stand is really excellent in crossability, flexibility, conformability, and the good thing for bifurcations is that it has a open cell to link design to allow a very good side branch access. He allows even over expansion. A 3.54, a platform like this could be over expanded.
What is the length?
It's 18 millimeters. Yes, okay. 18 because I saw that 20 was okay or a bit large, a bit long, sorry. Then 18 was okay.
Okay, so you see on the screen simulation with a bench with the 2 wires in place and the stand deployed. I think time is very important also to have a fully expansion of the stands.
I like to do 2 dilatations because I always see a further expansion in the second. Always I do 2. Yeah.
And you know, we learned from Gérard Finet that when you do a second time inflation, the balloon is a little bit bigger at the same pressure.
Yeah.
So it increases a little bit the size of the balloon.
Exactly. We are going to 12, 14, then we're going from 3.6, 3.7.
So what is interesting, we see that on the bench, is that after a full deployment of the stents, of course, you have a poor apposition of the stent proximal to the bifurcation. And we can see the space that we have proximal to the carina.
This is the result after stenting. Okay. As expected, the side branch is a bit pinched, and we have the carina shift. And we have now to open the side branch.
Will you perform proximal optimization before?
Yes, we are going to do first. Yeah. We are going selecting the balloon. I was looking that we have here a 4 because we have an 18 millimeters balloon, and I think that 12 millimeters are proximal to the carina. We're going to use this non-compliant balloon, this AQ-Force from TERUMO balloon, non-compliant, 4 millimeters and 12 in length. We're going to place the balloon exactly proximal to the carina as the pod should be done. And the pod is important because you restore the geometry, as Thierry explains very well in his presentations, and you can facilitate side branch access through the proper distal cell. I'm going to keep both wires, and I'm going to use a third one. See, we are just placing the balloon in a non-compliant. I repeat, look at its malapposition because now it crossed in. Sometimes when it's an indication that you have malapposition proximal and you need the pod because the balloon is crushing against the proximal edge of the stand. This is the point for exactly. Ahí, 6. We are proximal to the carina. Dale ahí otra vez. A 8. Now it's better. Vale. Now we have the pod, which is done.
So of course, it's very important to do the pod at the right place, up to the proximal part of the stent, but also very close to the carina because this is where you will access toward the side branch with the third wire.
Yep.
So sometimes you have to do several pods in order to be able to have an optimal apposition up to the proximal part of the stent.
Okay, in order to cross, you have to be really pretty sure that you are not malapposition behind the stand. Then we go from distal to proximal. Vete dando chispi. Contrast. Dale ahí.
Yeah, I think it's a very important step. Just a pullback technique, so orientation of the wire towards the side branch, and pullback, and it's jumping in the side branch.
Okay, we just cross there. We can remove the other wire, which is this one.
Very nice demonstration of the pullback technique. Of course, you can use a wire from the main branch, but in this particular case, I think using a third wire is safer because access toward the circ is a little bit more complex as compared to LED diagonal bifurcation, for example.
You're right. We sometimes use the wire in the main branch distally, but I don't know. I would like to have the wire of the stent always there. And when I rewire, I get a confirmation that this is in the true stent lumen going very distally. And then if I am very distally without problems and the wire is moving very free, you are pretty sure that you are not behind the stent, and you can go in the pullback technique to crossing to rewire.
Yeah.
So,
and also because you have done a good proximal optimization technique,
yes,
the risk of outside is very low.
The rear ray balloon crosses the cells easily, smoothly, no feeling of resistance. You know, you can see the marker of the balloon. I like to start with a small balloon.
So what is the size of the
It's 1.5, just 1.5.
Ah, okay.
Ahora prepara un 2,5. $15.
So do you plan to use semi-compliant or non-compliant balloon for?
For the first, we're using the 1.5. Now we're going to use a 2.5, and this is semi-compliant because we are going to use it for the kissing afterwards.
Okay.
And I should because there was no calcium, and I am not so concerned about expansion. But if I see any kind of sub-expansion in this balloon, immediately you can move to a non-compliant balloon. AccuForce is a non-compliant balloon with a good profile, but there are others non-compliant balloons that are not so friendly, and sometimes it's, the tip is the balloon is thicker, the tip is not so good. The tip of this stand, the Ultimaster, for example, is a very good tip because it's designed to prevent cracking, flaring, hand nailing. It's very tapered. Look at the balloon is crossing without any problem. Okay, we are there. Look at, this is just 8, and we have a good expansion, 10, 10, 10. We have to do, the new generations, they do inflations, very short inflations. They implant the stents in just 4 seconds. I think we have to keep the balloons inflated for a while, for longer, not just so fast. Because you see the gain with time. You see the gain with time. This is more dilated than at the beginning of the inflation. If I do all the cine, you can see that now it's more inflated at the beginning. I didn't change the pressure.
So what we can see in the bench is that when you inflate the balloon, you went through that strut, you have attraction of the stent opposite to the origin of the side branch. This is why we should do a final kiss or at least a repot at the level of the carina. I have to say that usually I use directly the AccuForce, a short AccuForce balloon for the side branch without pre-dilatation with any balloon, because in the majority of cases you are able to cross without any difficulty. So now you will kiss with 2.5 in the side branch and 3.5 in the main.
3.5 in the main. A la vez, venga. Sube. 2, 4, 6. A la vez que yo. 6. 6. Sube, hija. Sube. 6, 8. Sube 8. 8. Déjame a mí este. Now it's better?
Yeah.
Okay, we pre-dilate more with this. Yes. And let's do again. A new, venga, come on. Venga, sube, conmigo. Sube. 6. 4, 6, 2, 8. 8-10.
It looks good, huh? So what is important when you do the kiss is to have a simultaneous deflation at the end.
Okay.
In order to have the carina which stay in the middle of the bifurcation.
Vamos a retirar.
So what is the next step? Will you do a repot or go directly?
I'm going to do repot. You need to do repot because we have the 4 balloon, but please, because as you say, we have to restore the circularity. The kissing is induces the kissing induces eccentricity of the proximal stand, and we need to circularize again the proximal, the 4, el balón de 4.
Yeah, I fully agree. Of course, we cannot see that on the screen, on the angio, but
exactly. In the angio, you would say it's fine, we finished, it's okay, but it's not. It's not. It's not.
I agree. Especially if you use long balloons. Of course, if you use a short balloon and you do the only in the polygon of confluence, maybe you don't need to do a repot. But if you use long balloons, you have to do it because you have a bottleneck effect proximal to the carina.
This is going to be the sequence: pot, kissing, pot. Other people do sometimes pot, side branch, pot. But I think the kissing was important here because it was a large main side branch.
Yeah.
And you need to have a good result. It's important to say that the balloons were large because 3.5 and 2.5 through a 6 French, and I didn't feel any resistance or difficulty in the positioning and placing of the balloons. That is a good thing about the balloons. Rear ray and acute force. Again, it's important to tolerance for overexpansion of these stents because in this case, in the stent proximally maybe is going up to 5, but the large platform on the Ultimaster Tensei tolerates up to 5.8, which is really large. Yes.
So this balloon is 4012?
Yes.
The same as before, yeah.
12. It's important to do the pod, as you say, very exactly in the position because you see this very distal. You, again, displace everything to the side branch and you pinch the side branch again. If it's too proximal, you don't do the job in the polygon of confluence, then you have to be in the right point.
Yeah.
It has to be in the right point. Okay, prepare the of the eye. We are going to do the of the eye. Now, when we have the stenting, we have the science branch work done. And we are going to do some projections. And we are preparing the Luna wave for FDI and the catheter to check internally. That should be done in large bifurcations, particularly like this or the left main. It's very important to have imaging. What do you think of the result, Thierry?
It looks very good.
I think it's good. You should not
nice.
Exactly. You should not expect a 0% stenosis in the side branch, but in this case is less than 30%, and I think is adequate because some people feel the temptation of stenting very easily.
And with the nice technique that you have used, I will be surprised to see something unperfect from OFDI.
Okay.
Yeah, it looks very good.
I guess go to do the OFDI. We did the pull back.
Yeah.
And I don't know, maybe you can you see it, the OFDI run?
Yeah, absolutely.
Oh, good. Vamos a retirar el catéter, no hace falta más imagen. No, de entrada no, retira. Retira. OFDI, you can adjust the length to run, to examine, it's very good. And we're going to show this distal edge. Very important to see if any dissection. You can see the vessel. No dissection in distal edge. Some with the distal. No, this is the stent, distal. That's it. Okay, go. This is the distal vessel, healthy vessel. This is the stent. Nicely opposed and expanded.
Yeah, good
Let
transition.
me see.
Between
Look at the bifurcation, the other wire. Of course, and eccentricity in the polygon where the plaque was. And very, very, very mild malapposition. Vete a la proximal, vete proximal. You know that you can tolerate some minor degrees of malapposition because look at, stop there, stop, no, before. Just there, stop. Mide del estrato a la pared. If you measure the maximal distance, is so tiny that it's 0.15, 0.1.
Yeah.
Really, it's nothing. And the risk of going more aggressive in these cases is maybe to dissect or even rupture a healthy vessel at that point. What do you think, Thierry, with this very, very tiny, small malapposition?
No, I fully agree. I will not touch this. We know that it's not an issue. We need to have really a malapposition in terms of surface. I think it's better. But in this case, it looks perfect for me.
Show again,
Distal
please.
part, proximal part, bifurcation.
We're going to show the most important, the critical, where we can see the, look at, where's the minimal area there? There, that's that point, 8.6, which is excellent minimum stain area for a circumflex, which is really good, even will be good for many mains. Thin 8.6 is excellent. Any further intention to enlarge that point could be in detriment of the side branch. We have to keep this in mind. And 8.6 is an excellent area. The diameters are, you can see 3.83, the diameters at that point. So, muévete la bifurcación again. We're going to see where the circumflex is. Look at there, look at the wire is coming up at 12. Go para allá. Proximally. Look at there. Good opening to the circ and a good lumen. Then, Thierry, I think we finish.
Absolutely, I like it very much.
And let's place the wire there. I like to place the wire in a safe position, just doing the final angios. In case a suboptimal side branch result, we were discussing that maybe the alternative would have been, of course, to do T or TAP in this case.
Absolutely.
Good. Other alternative, if the side branch would have been more affected, is to do an inverted provisional. It's a suggestion that Thierry made, and very, very convenient suggestion, because sometimes it's not common at all, but sometimes it's the inverted provisional, not Thierry, is when the side branch is really very diseased and maybe you and the distal main branch is much more healthy. Maybe the inverted provisional could be an alternative.
Yeah. Absolutely, but in this case, I think the strategy was the best one. Of course, if needed, you can add a stent in a T-shaped configuration or tap if you are not sure about the ostial positioning of the stent. I think it's really a very good result. So maybe time to conclude the session.
Yes, we can conclude the session. It's a 101 bifurcation in a large vessel. In this case, we opted for the most common strategy in the large EULT master registry, which is over near 40,000 patients. In bifurcations, near 80% of cases were treated with provisional, 76%. Then we follow the most common strategy nowadays, which is currently the provisional. We pre-dilated the main branch. Then we stented the main branch according to the distal. We did the pot with the 4 millimeters. Then we rewired the side branch, which is really important to do it properly through the distal. And after rewiring, we dilated the side branch, the cells that send to the side branch. And we finished with a kissing balloon, properly sized, and finally a pot. The sequence is pot, kissing pot, which is really the sequence that is more, I could say, indicated in cases like this. Then with only one stent, very good stent for this kind of lesions, we just fixed the lesion of this kind patient. We also showed the utility of the CT, the of the eye, because if the eye confirms the good result that angiography is not so sensitive to show.
Thank you very much, José. I think it was an excellent demonstration with a very interesting case and a very nice result.
Thank you.
Thank you. Bye-bye.
Bye.